All right, you guys ready to get started? Let's do it. Good morning. Thanks everyone for coming. I'm on East Coast time, so this is great for me. So talking today about new care delivery models, what the next decade looks like, and we have some great leaders across the behavioral health spectrum to talk about the various perspectives in how they're thinking about addressing some of the needs that we have in behavioral health. My name is Corbin Petro. I've been in healthcare my whole career, largely working across alternative payment models, working with vulnerable populations. I founded a company called Eleanor Health and have been advising about 10 to 15 companies over the past year. One of them is Wave, so excited to be here supporting Wave and supporting all of these great organizations. So we're just going to go down and make sure everyone knows who everyone is and go through. So if everyone could just give their name, organization, and one sentence, if you can do it, on what your organization does.
Yeah. Can everyone hear me? Okay. I'm Dr. Ariel Radin-Pulverman. I'm the co-founder and CEO of Bruin Health, which is a technology company that augments providers with behavioral health intelligence in support of all chronic diseases.
Good morning, everyone. My name is Dr. Donna Milovitz. I'm the Chief Medical Officer for Regions Blue Cross Blue Shield. We are a regional Blues health plan serving Washington, Oregon, Idaho, and Utah. And I do all clinical strategy, quality, and health equity for the organization. Glad to be here.
Good morning, everybody. I'm Karen Mitchell. I'm the Chief Growth Officer at Quartet Health. We're a value-based care, behavioral health specific organization that does care delivery. And we do it we take risk, and we do it for all what we call whole health. So we take both behavioral and physical health care and take care of our patients.
Good morning. I'm Sarah Adler. I'm the founder and CEO of Wave Life. We are a behavioral health step-to-care model that leverages data, technology, and different levels of providers to encourage them to work at the top of their license to provide better, faster, and cheaper healthcare for all.
Good morning, everyone. I'm Svetlana Livak. I am Director of Product for Behavioral Health at Northwell Health. Northwell Health is a large integrated health system. We serve the community in New York City as well as the surrounding areas, and we're also a large employer. We have 80,000 members in our self-insured plan.
Awesome. So if people didn't catch it, we have a payer, we have a large hospital system, we have services providers that both deliver the care as well as augment care. So a really great mix of folks here. Let's just start with the supply-demand imbalance that we have right now. Obviously, there's been an increase in demand for behavioral health services, particularly since the pandemic. We have an issue where there's more demand than there is supply, particularly for traditional behavioral health services. So I really want to just talk about what your organization is doing to address and to close some of those gaps. So we'll start with Sarah. How does coaching support expanding access and closing gaps in care?
Yeah, so we have actually found that using evidence-based treatment and disseminating it through both technology and also lay healthcare providers can get equally, if not better, results than leveraging licensed therapists for almost 75% of conditions and acuity out there. And so we've chosen to focus our model on using predictive analytics to indicate who belongs in what care pathway at what time, really when it is okay to put someone with a lay healthcare worker. So we're leveraging mostly coaches. 80% of our population is treated using our two primary steps, our app-based self-guided programming, as well as our health and wellness coaches. They are far easier to train, far easier to really get to adhere to evidence-based practice than people like me who are licensed clinical psychologists, and really can procure significantly equal, if not better, outcomes. So it's a much more scalable supply of human capital. I hate to call our providers that. And so it's an incredible way to sort of combat the supply and demand imbalance.
So being a devil's advocate, what are some of the risks of so coaching? There are a number of different platforms that are delivering coaching. What are some of the risks in a coaching model that might pose quality or other issues, and how do you protect against, essentially reducing the bar, reducing the friction to becoming a provider of mental health services?
I think it's such an interesting question because I think there's a sort of a fallacy or a misnomer that just because someone has a license means that they are going to be providing high quality care. The only way that we actually can see if someone is providing high quality care is to measure outcomes. And that's fundamentally what we do. So we train, I've been training licensed therapists for 15, 16 years at this point, and I can tell you that the only way to make sure that they're providing good quality care is to give them data and feedback to ensure that they actually are doing it. So we found the same thing with our coaches. We train them in evidence-based dissemination of evidence-based models, and then they can actually apply it. As long as we're doing our job in terms of ensuring quality control, we can make sure that folks are, again, adhering to the evidence base and making sure they're delivering the highest quality care possible.
Don, I want to put you on the spot as the payer. So as a payer, you have a bit of the responsibility, but you also have a balance of essentially allocating these resources. So on the one side, you might have a commercial client who really wants recent and quick access for their employee population that might have low acuity needs. And on the other side, because you're across all lines of business, you have a Medicaid book in one of your markets where you have populations with serious and persistent mental illness who are unhoused and who you need to really allocate those maybe same resources in a different way. So how are you thinking about that?
Yeah, so great question. So again, speaking from the health plan perspective, framework for us from our behavioral health strategy really is access, connection, and quality. And within that framework, we take a population health strategy across all lines of business, keeping those low acuity, almost that prevention, as I say, life skills management strategy, all the way through those chronic at risk where the intersection of behavioral health and physical health happen, and then serious illness. We also take a very disease-specific approach from our strategy, looking at our data to find out where pockets of the population need more need than others, again, across all lines of business. And then lastly, there's different levels of acuity, whether or not it's an outpatient professional versus an inpatient versus residential treatment. So we are looking at that across a multitude of different types of providers, whether or not it's a virtual-only approach, whether or not it's a hybrid, whether or not it's a brick-and-mortar in-person and hybrid approach. So we're constantly looking at our 4 states, which interestingly, right, we have 2 very blue states, 2 very red states in our footprint, which have very different political agendas when it comes to behavioral health, which we're also navigating in that space. But using a data-driven approach to help us make sure that not only we have network adequacy, but more than adequacy, it's expertise, and especially in those specialized areas that we need to support our members across their lifespan, and looking at that through a social drivers of health spectrum as well.
That's helpful. Ariel, talk a little bit about how your organization is not taking risk and not delivering care. So where do you fit into the ecosystem to help address some of these imbalances that we see?
Yeah, so we are a pure play technology company. So where we're really trying to make the biggest impact is where most of mental health care is currently being delivered, which is in primary care. So instead of trying to shore up resources or providers that might not exist in certain locations, why not give those primary care providers the intelligence that they need in order to effectively treat the patients at the point of care? So when that patient is in the room, giving them the ability to know exactly what to do in terms of making a diagnosis, understanding what's underlying that patient's symptoms, iteratively creating and updating their care plans, and then also helping coordinate care between that primary care doctor and other community resources or other providers that might be available to the patients, either locally or virtually, digital solutions. You can really think of us as more of the glue that's trying to stitch together, patients and their care teams within primary care and all of these fragmented services, either locally or virtually, that patients and their doctors might not even know that they have access to.
Karen, at Quartet, you started in a similar place to where Ariel did in sort of creating that connectivity with primary care, and you moved into care delivery. So maybe you could talk a little bit about why you felt that was an important part of your strategy and a critical component to what you were trying to do.
The connectivity is extremely important, and we still do it today. We've been doing that for 10 years, and what we found is that we have proven statistics that if you can connect patients that need care to behavioral health care, their overall cost will go down, their behavioral services will go up, but the overall total cost of care goes down. What we found is that for the low acuity and the moderate, those people are actually going out and getting those services, but there's a pocket of SMI patients that are not getting those services. And so we've actually strategically moved into the overall effort to go out and treat people, like I said, in a whole health way. And so we've got an entire care team that's kind of wrapping ourselves around those members and trying to figure out what it is that they need, and we're meeting them where they are, as opposed to being a distant referral source, if you will. And so we're seeing those patients in the hospital, we're seeing them at home, we're knocking on their doors, and we're kind of treating those patients holistically to determine what their needs are. And I can talk more about that later, but it has been a big change, and I can tell you from a marketing perspective, as we're talking to health plans across the country, the SMI population is one that is, I don't want to say neglected, but doesn't always get the necessary attention they need.
So I'll go then to Svetlana at Northwell. So large hospital system, obviously part of an ACO, so has inherent risk as well as obviously for your large employee base. So how do you think as a large system that has this ACO risk, how do you think about buy, build, partner, and where you're investing to build those capabilities, and where are you looking? I'm sure folks here that are trying to sell to you would love to know where you're open and looking at partnerships and acquiring services elsewhere.
Yeah, in Northwell Health, we are trying to close that access gap that we spoke about for our community, our patients, as well as our employees. As I said, over 80,000 employees, as we're a self-insured employer. And so in our behavioral health strategy, we're focusing on developing some homegrown in-house kind of digital behavioral health solutions for our employees. And then we're also partnering, setting up external partnerships with other companies to treat our whole community. So for example, what we did for our employees and we're doing now is we partner with our benefits leaders in order to develop a virtual care navigation and care delivery product. With this desire to want to deliver high quality, effective care, as we are a provider. And in that partnership, we built out a digital solution that offers evidence-based treatment, also measurement-based care, and a curated directory of in-network providers. We've also, kind of for our community of patients, which is a much larger reach, we've set up several referral partnerships where we are, as an ACO, screening across the health system, identifying patients in medical services. And we set up a care navigation kind of digital front door to be able to connect patients to these external referral partners where we are kind of relying on these other companies because the reach is just so great to close that access gap.
What portion of those referral partners are within your geographic footprint, sort of more traditional versus new model 2.0, where it might be more virtual or they're sort of emerging players? Like, how do you think about that balance? Where when I think about referral partners, it's a lot of like traditional to traditional, and so curious how you're thinking about sort of looking at new and innovative models.
Yeah, I would say we did a split. So we do have a couple of community-based organizations that we partnered with for that because, again, we have a lot of reach in New York City, but we also partner with several digital companies to be able to provide those referrals, which is very new for us. And so we're sending folks for virtual care with a different external digital behavioral health solution. We're also using a lot of these kind of companies that target access to be able to find providers and match individuals with those as well. So a bit of a split, and we launched in October, so it's fairly new, but we are looking at those numbers now, and we see kind of an equal split of where we're sending folks.
So switching gears a little bit, I think we alluded to this a little bit in some of the responses, but near and dear to my heart is value-based care and alternative payment models. A lot of the services that are provided, obviously many of the organizations here take risk. How important is value-based care or alternative payment models to advancing new ways of delivering care? How important is it, and what traction are you seeing sort of in moving those models forward? I don't know who wants to start. Maybe Sarah again, just given that coaching is traditionally not reimbursed in a fee-for-service environment, yet it has some of these great outcomes, so makes it hard from a growth perspective. So how are you thinking about that?
It makes it a challenge from a growth perspective, absolutely, but we're willing to fight that fight. What we found actually is that if you really segment it from the health plan space versus the employer space in terms of who is paying is really a good question. We've actually found great partnerships with health plans who are based on the fact that CMS has actually approved codes in Category 3 that are sort of filtering down into the ecosystem, into the commercial ecosystem for health and wellness coaching. Health and wellness coaching has been actually around in the tertiary medical market for a very long time in helping folks make behavior change associated with cardiac care and cancer care. And so now we're sort of leveraging those same codes that have been approved, are making their way down into the commercial book. And we've actually found with good conversations, and because we're so insistent on measurement-based care and outcomes, that the outcomes speak for themselves. So payers, generally when they are looking at our outcomes and they see our kind of robust clinical model and the fact that we're doing evidence-based practice, we've actually been okay having conversations for most payers. They want to know how we're doing quality control, much to your earlier question, and how can we ensure that the right person's getting to the right place at the right time. But a good data story, I think, as every single person on this panel has alluded to, really makes the fundamental difference in terms of gaining traction. On the employer side, and I'll wrap up, quickly, we've actually found different payment models that the employer side, it seems to be desperate for it. I cannot tell you how often I've had the conversation. I'm happy to do PEPM, but it doesn't align my incentives with your incentives in terms of getting uptake. And what we really want to do is be integrated with you as a partner. So we've actually moved to usage-based pricing. And because, of course, we have data, we have outcomes, we have incredibly robust measurement, we can afford to take that risk. So again, I think it's the sort of agreement or the tension between what the companies are trying to align around in terms of value-based care has been the tricky part, or the rate limiter. We're happy to take risk. We know we're going to get your outcomes. So
the main approach has been getting payers to adopt and to promulgate some of these new codes, and so allowing your service to fall into the fee-for-service reimbursement. Have you been open to pay-for-performance or other sort of quality-based components?
100%. In fact, I encourage it because it, again, we can stand behind our data, and we also want to make sure that internally that measurement-based care is a very, very difficult thing. It's not just building the technology. It's about creating a culture of measurement. And so from a top-down perspective, integrating that into our clinicians' kind of mindset in terms of driving quality outcomes prevents drift. It gets you just better outcomes in general. And so we're willing to play in the fee-for-service market. We're also willing to take tremendous risk on SLAs and value-based packaging as well. So we'll do whatever.
Donna, I'm coming after you. We've worked together before, and I think a lot of it from a payer perspective is there's often a lot of alignment around goals. Value-based care, you're moving in the same direction, you're aligned, and then you hit a roadblock because the payer has a really hard time administering some of these models. So what models, what reimbursements have you seen work? Where has your organization invested to say, yeah, this is a place where we want to develop a value-based model outside of primary care or ACOs?
So great question. I want to take a slight detour to go back a little bit in terms of setting the table for these advanced payment models from a payer perspective. I think at Regents, we fundamentally believe that aligning incentives in this value-based space is very important for where we're going. And we've been in the value-based space as healthcare for a really long time now. But we've also just come out of a pandemic. Inflation is at sort of an all-time high. Workforce pressures in the provider space have really, in the physical health space, our provider partners are retrenching and saying, we don't want APMs. We want straight fee-for-service. It's a guaranteed income stream for us. And so in that whole side of the house, it's an interesting conversation. And again, a lot of these partners have integrated care. They have behavioral health providers within them. So it creates a nuance for us in this APM space. I will say, just from a straight behavioral health standpoint, we believe in the sort of the crawl, walk, run, sprint philosophy at Regents, that it is a new place and a new space as a sandbox and maybe even blue sky to say, what does this look like? Traditionally, payers have not used patient-reported outcome measures, right, as a quality measure in the behavioral health space, even though that's the right thing to do. It's ironic to me that, like in the physical space, we have blood pressure, we have HEDIS measures, like we have all these other validated measures, and even though we have those in the behavioral health space, we tend to not use them as much. So in terms of sort of just being sort of very specific, I think we're starting in that case rate space, knowing that specific in the behavioral health arena, there are different care delivery models than the straight fee-for-service. And in behavioral health specifically, that doesn't work so well, that straight reimbursement. So moving into that partnership of what good looks like, testing and learning, making sure that there are aligned clinical financial outcomes. And then, to be fair, leaning in as a payer to say, yeah, we're going to see an increased use of professional services, being comfortable with that, because on the backside, it's the downstream reduction in, let's say, avoidable emergency room or inpatient hospitalizations. So it's sort of riding that wave and feeling comfortable. I hope that sort of helped scope that.
Yeah, are you, from a data perspective, are you able to actually link together the behavioral spend and the physical? Like, just be honest, the behavioral spend and the spend and the physical spend.
Yeah,
right? Like
I think we're on a journey. We're on a journey.
Okay.
How's that? To be totally candid, you know, when you look at a total cost of care, right, which I'm not sure is the best measure, because spend is going to go up initially, right, with increased utilization, which is candidly what we all want in this room. But selling that to the CFO is a little bit challenging, to be fair. So yeah, I think we're on a journey. I think most payers are on a journey with that. But I think the pressure from providers, from employers, from the marketplace, from mandates are all going to help us move to that next level.
Yeah, I think just to wrap that, what I hear a lot from payers is you have different P&L owners. You have the P&L owner of the behavioral health spend, which is different than the P&L owner of the physical health spend. And so the BH P&L owner doesn't want to see that increase, even if it's going to decrease. Together, it's a win, but separately, even within the same organization, it's not a win, and that's maybe holding us back. Which brings me to Karen, who's, you know, you're trying to take on total cost of care risk for serious and persistent mental illness, as you mentioned with your whole health solution, which I know you announced here at BHT. What, you know, I think the use case or the case study was with what I would call like a payer 2.0 model, Clover. So what are you seeing from some of the legacy insurers? Where are you seeing traction in that model?
So first and foremost, we're only really talking about 5 to 6% of the overall population has SMI. So you're really talking about a small number of members that have a very high cost of care. And they're not going to go out and get care. And as Donna said, quite frankly, the amount of risk appetite across the payer spectrum really varies. And so we're willing to kind of meet those payers where they want to be. However, if you just think of fee-for-service from a behavioral health perspective, we can't really make money because the reimbursement is so bad. So if you really want to have a care team that's multidisciplinary, that's going to go to a patient's home, that's going to have some virtual care and kind of match up SDOH needs, and you kind of take that whole whirlwind of need from a patient's perspective, an APM is really going to allow us to move the needle and help those members and reduce the overall cost of care, as opposed to some kind of fee-for-service that really will not work. And so what we're seeing in the initial results is that If you wrap that care team around and you identify their social needs, which are much higher than I think we initially expected, the patients are engaging, and once they're starting to engage, we are starting to see early indicators that the overall betterment of those members is actually occurring.
So in this model that you've developed had great outcomes, what portion of the care that you're delivering, I'll call it care, but interventions, would not be reimbursed under fee-for-service? Like what portion of that basket of goods that you're providing wouldn't even be covered under fee-for-service?
So think about a nurse practitioner walking into the home and seeing a patient. And you meet that patient, and all of a sudden, we do a whole series of assessments, depending on what conversation you have with that patient. Those assessments then lead to new needs. None of that would really occur. And we're referring out. So if this patient needs transportation services, we've got a partner that can help them with that. If they need to apply for Medicaid, we've got a partner that can help them with that. So if we need to help make sure that their medication is adherent, we can do that. Many of the services that are occurring while we're interacting with that patient would not necessarily occur, because you would have a single clinician that has one single goal, and they're going to go in and out.
Svetlana, your organization is part of an ACO, so how does having that risk enable you, or maybe it doesn't? I think about those referral partners in my head. I keep thinking of traditional referral partner, but how often is it a provider that isn't reimbursed in a fee-for-service way, and how does that payment then work? Like, how does that entity get paid?
I'll give you an example of where I think we were able to change kind of some of those traditional payment models by partnering with our benefits leaders to innovate kind of what we're doing for our employees. And in that partnership, we did a whole benefits redesign of how are we going to deliver care, because we do know some of these challenges around getting reimbursement and all that. So we were able to negotiate a premium fee for our providers, and in turn say we're not going to send any bills right to our patients. So they're never going to see any cost for the care. They're never going to have copays or any other fees that they would be responsible for, because we had that premium rate. And that in turn allowed us to confidently grow our network and drive access into in-network care, which is a huge thing that we want to do, especially for the employer and the employees, where the cost out-of-network fees are really expensive. We saw really low in-network utilization for behavioral health in comparison to medical services. And by setting this benefits redesign up, we were really able to drive 90% of our employees in network, which is really huge. As I mentioned, there was very low utilization before then. So it's kind of like what's possible if you do partner with, and we're able to do that because we're self-insured. But it would, I thought it was a great movement in the care we're delivering.
I want to shift a little bit to outcomes. Everyone here has talked about focusing on outcomes, and I'm sort of like, what does that even mean in behavioral health? And so we'll start with Ariel, who, your model is really predicated on outcomes and sort of shifting the paradigm a little bit in how we think about outcomes, which is a really hard charge. So I'd love to just hear how your organization is focusing on some of those root causes as a mechanism to get to better outcomes, and then what does that mean?
Yeah, thank you. So I think something that's really unique about what we're doing is we're trying to not only measure symptoms across different diagnostic classifications, but also trying to measure the psychosocial factors that underlie those symptoms. So we all know, or maybe we don't, but two people can have the exact same scores on the PHQ-9, but that doesn't mean that they need the same treatment, right? We don't actually know what's driving those symptoms. And if we could actually get to the root cause of what's driving those symptoms, we could more efficiently match patients to specific types of care that would be right for them. So for example, maybe this person doesn't have major depressive disorder. Maybe there's something, socially that they need. Maybe they actually just need housing support, and that's why they're experiencing depressive symptoms. So we really, really try hard to get to the root cause, just like we would with any other condition or chronic disease. And once we do that, we can actually assist individuals at either subclinical levels of behavioral health problems that we know might be driving physical chronic conditions like diabetes or cardiovascular disease. And then once you're able to do that, I mean, our outcomes can really be patient dependent. So maybe within, endocrinology, we really want to be measuring more at the level of A1C levels, or maybe, in cardiology, blood pressure is going to be more important for that patient. So I think instead of just trying to measure PHQ-9s and then look at clinically significant reductions in those, which might be meaningful to some patient populations, we can actually get much more specific for individuals to figure out what's meaningful for them.
And so how does that track back to providers that you're working with, and then those providers working with payers? Are you saying that those metrics and that approach is something that is starting to be recognized as something that's impactful and worth maybe paying more for, or what are you seeing across that? Because it's all about, I hate to say it, in this space, there are a lot of organizations that are improving outcomes, but those outcomes aren't ones that anyone else is looking at or tracking.
Yeah, I think right now, to go back to payment models and how this actually gets funded, right now there are a lot of fee-for-service opportunities for integrating behavioral health care, and that involves regular outcomes monitoring, and that could be anything, that's not dictated by PHQ or GAD-7. It could be whatever is clinically relevant for that patient. Same with chronic care management and that ongoing code. I'm really excited about new value-based arrangements that are coming out that I think it's going to be a lot easier to show impact that's meaningful for given disease states or different chronic conditions. So one that I'm really excited about that's coming down the line next year is the ACO primary care flex model, which is actually going to allow primary care groups in more rural areas to have more money to spend on services like ours. The problem is there just aren't enough services providers in those rural locations. So they're going to need technology solutions that actually equip the existing services or the existing providers that are there to provide higher levels of behavioral health care within those practices.
So Donna, which ones do you care about?
It all comes down to affordability. I think at the end of the day as a payer, which is a blessing and a curse, right? Because if healthcare isn't affordable, then people can't actually access care, right? It's sort of that vicious cycle. I will say that I think we're at the beginning of this journey. I think there are some crude measures right now that we're utilizing. Some of them are the standard patient-recorded outcomes in the behavioral health space that now we're sort of requiring providers to regularly report on, similar to what they do for clinical HEDIS measures. But candidly, as a payer, we are looking at financial outcomes. Is there a decrease in utilization of unnecessary care or high-cost services as a result of leaning into improvement? My fabulous executive medical director for behavioral health is sitting in the audience, Dr. Franz, and he says to me all the time, which I love, and I will say to publicly, it's no longer 50 minutes in a fern. There has to be some type of outcome for that service, similar to if you came to me as the general internist, I have clinical outcomes on lowering A1Cs and getting to go with blood pressure. And so pushing providers in the best possible way, speaking as one, that having that engagement and the downstream tangible reportable outcome for it is really where we're heading towards. But my hat's off to any payer who's figured that out yet, because we haven't. But I think, if you go back, 5 years, we weren't even having these conversations. So I think we're at the beginning of the journey, and I think we need everyone in this room to help push us, right, as a payer, show us what good looks like, give us those innovative models, partner with us, let's do some test and learning to understand that, because I don't think we have it all figured out yet.
So one tactical question, when you think about the financial impact and financial affordability, over what time period?
Oh, well, all health plans do it over a 12-month period of time, right?
But
I'll just
I
own
was
that
setting
in
you
the
up for
room.
success, yeah.
Absolutely, which, again, is a mind change, right, for payers. But, in defense of us, I will say, we have by line of business that is also changing, right? In the individual or the exchange marketplace, those are very transient memberships for us. But in the Medicare line of business, we have very large retention. Our ASO customers, very large retention. So, all of that plays into the logistics of how do you calculate ROI, to be specific.
So I'm about to turn to the audience, so think of questions, and I forgot the iPad, so you'll have to go with the mic. But just to sort of wrap up this outcomes, Sarah, I know you as a clinician want to talk about clinical outcomes, but coming off the backs of Donna, how are you reducing costs over a 12-month period in your program?
Yeah, I think it's so exciting to hear Donna. I'm like, we should talk after maybe, because we're so aligned, and it really is about getting innovative models to align around clinical outcomes. I think you said a couple of super interesting things. One is kind of sort of this, like, what does it even mean to have clinical outcomes? And I think we really are at the beginning of the journey for that as well. And so we really think of ourselves as a data company, a responsible data company. And our job is actually to help the payers figure that out as well, because we're the ones who have the ability to create the culture to get the folks to give us the information, whether that be through their Aura rings, whether that be through patient-reported outcome measures, which is kind of the best we have right now, absolutely looking at social determinants of health as well, and starting to create those models that can really actually help us eventually come to the place where we can start to understand what do good outcomes mean. In terms of getting to 12%, we've got 75% of our clinical users, our patients who give us clinical data. And again, the really, really hard part that I think most care delivery folks do not actually understand is that it's not just about building the tech. It's about how do you integrate culture of measurement into your system? How do you get your clinicians bought in? How do you get your patients bought in from day one? And then what ROI are you looking at? How can you partner and be really flexible about your data and understanding what does this provider want to see versus what this provider wants to see, and not to be too precious about any one set, because one provider might be, one payer might be incredibly advanced and sophisticated about this conversation, and another might not at all. And I will just sort of parrot and just say, when I started in my career selling into health plans and self-insured employers and folks, these conversations were not happening at all. We were the ones who were collecting the data and presenting it to health plans and kind of saying, because it's really also very expensive to aggregate data, and that's something that I think the health delivery system actually has to take some responsibility for, and working in partnership with folks who are paying, because y'all are doing a lot of other stuff as well. So, yeah.
All right, audience, who's got some questions? Let's do it. There's the mic if you want to stand and really put yourself out there.
Hi, my name is Lisa Bertola, and I have some large group health plans that use their EAP to get the front door open, and then for higher levels of care, they create a clearinghouse within the health plan to pay for those services that go beyond an accepted benefit. It's good and bad. What do you think? I know like Eleanor Health and others are in their suite of specialty care, complex care services at those higher levels, but we're still segmenting data. We've still got HIPAA regulations to observe. It's still disconnecting care and measurement. What do you think about that? Is that good, bad? Is it an interim solution? And how are you working toward change?
I'll speak to that a little bit. I think it goes back to kind of what I was saying, is that you have to think about this as an integrated vertical solution. If your providers and you have to align the incentives to drive measurement across every single stakeholder in the system, from the person who's paying for the service down to the user who's understanding why they're giving it to you. Measurement also increases the outcomes. So the incentives are completely aligned, but you actually have to create a culture that doesn't separate from the providers. Providers need to understand what the agenda is as well. The user needs to understand what the agenda is. And there are ways to do that from implementation science perspective, as well as from a user experience perspective, that are solved problems if you can actually connect everyone in the system to be driving towards the same goal. Because I think I'm going to say something super controversial. Part of what is really broken in our healthcare system, and especially in behavioral health, is the incentives are not aligned. So let's work as where everyone on this panel has talked about in terms of how do you actually align all of those incentives, and that starts with measurement. It starts with data.
Hey, can I jump in for a second? I think it's a really important question that you asked, because it's a really it's a segmentation of benefits for a oh my gosh, sorry about that. My daughter's calling. That I think an employee or a member doesn't understand. Like, this is my wellness benefit, which is different from my medical benefit, which is quite candidly different from my pharmacy benefit, right? So just a basic understanding of a member, of what the different resources are for them. And then because of some regulatory pressures, right, none of that wellness data, which EAPs provide a fantastic venue to help with the lower acuity care that is so highly prevalent in our society, that net never gets pitched over the fence, right? To say, like, because of this utilization with the EAP provider, we then avoided, getting back to the affordability piece, we avoided this many professional visits on the medical spend side. We don't connect that data, to your point. And it is a huge mismatch, I think, because it is a missed opportunity. I will also say that if you look at EAP utilization, and we have an EAP provider within our Regions platform, and we're very generous with that. We have 12 visits that are completely no cost within our own health plan, and we look at utilization. It's like 2 to 3%. It's crazy. So how do we start to socialize from a societal level that for the majority of providers that do offer an EAP solution in the behavioral health space, how do we then quantify that in a different way on the medical spend? I think it's huge.
Yeah, and when you think about EAP, it's really intended it's not intended as a bridge, which is what you're describing. It's intended as a solution.
Yeah.
And so we know how important that relationship is with the provider in behavioral health, and what doing a bridge, like, there's going to be a handoff, and you got to recreate, and could be sort of re-traumatizing in that next phase of the relationship. Super interesting. Who else? Who's got questions here? Were you raising your hand? I saw it. Somebody? I saw a hand. No?
I'm coming over the mic.
Oh, good, yeah.
So I like the idea of additional measures that seem more clinically relevant. Can anybody talk about examples of what those measures might actually be?
Would you say clinically relevant, like for
like an individual client? So let's say we've got somebody that's using a behavioral health service, and the PHQ-9 or the GAD-7 doesn't really reflect anything about what they're doing. Most of us yesterday might have had a pretty high PHQ-9 or GAD-7. Yeah. And so I think it's something where if there's how are we creating other measures that are actually relevant within a clinical, kind of psychological space versus random numbers?
Yeah, thank you so much for that question. What's wonderful is that we haven't had to really create any measures from scratch. So I have my PhD. Our team has a couple of PhDs on it. We love going into the literature and finding evidence-based assessments that already exist that just aren't really being utilized in clinical contexts. So, for example, the rumination response survey, really understanding maybe this person has a really cognitive style of depression, it's very ruminative, versus using the SHAPS to understand maybe this person's extremely anhedonic and they could benefit from something like behavioral activation therapy. So these are the types of measures that we're leveraging, really trying to get to the underlying root drivers that are explaining their symptoms, and we know that those are actually shared across different diagnoses as well. So I have a whole thing around the fact that we constantly see, if any providers are in the room, you see people with like 5 to 6 different mental health diagnoses on their chart. It's like, how helpful is this? when we know that there's probably like one or two main things that are driving all those symptoms. And if we just targeted those instead of cobbling together a bunch of treatments for each individual diagnosis, we could actually more efficiently treat that patient.
All right, we have about 1 minute left. I was going to wrap up, but I see you're dying, so let's do it.
I just wanted to expand on that question because I'm curious about maybe either like some of the research around like more biomarker diagnostics and like how that kind of plays into different types of care delivery models.
Absolutely. So I'm a psychoneuroimmunologist. So I love, measuring inflammation, stress biomarkers. And what's really cool about that is that those biomarkers are also relevant for these chronic diseases. So again, shared mechanisms. So yeah, thank you.
That's cool. Thank you. That's cool. So try to wrap up what I thought were some of the key points. First, obviously, we have a supply-demand imbalance. There are new approaches to care that can clearly close some of those gaps, but adoption has been slow, largely because of the fee-for-service and the reimbursement system. Movements in that space have also been slow, and so being able to be fee-for-service reimbursable and leaning on codes has been one way to get to market. Others have been, if you can get a payer partner, thinking about ways that move toward value-based care. And then we all care about outcomes, whether that's quality, clinical, human, financial is super important, particularly to payers over a 12-month period. And the space around outcomes is moving. And so traditional metrics and traditional measures, while they have a large data set behind them, we're moving forward and finding new ways of showing those outcomes. Does that sound right, guys? All right. Thank you all.
Thank you.
Thank you.